Today, let us learn about the management of acute asthma. What is asthma? It is a chronic inflammatory disorder of airways with reversible obstruction. What are the symptoms and signs of asthma? There can be breathlessness, cough, wheeze, tight chest, or nocturnal cough. What are things you will monitor in a case of asthma? You will monitor the respiratory rate and effort, heart rate, air entry, oxygen saturation, PEFR, peak expiratory flow rate if the child is more than or equal to 5 years, and the consciousness level. The symptoms and signs of asthma are variable, intermittent, worse at night, and provoked by triggers including exercise. Asthma is classified as mild to moderate, severe, or life-threatening depending upon the symptoms and signs. In a case of mild to moderate asthma, vital signs are normal. There can be a mild wheeze. The patient can speak in complete sentences. Saturation will be more than 92%, and PEFR will be more than 50%. What about severe asthma? In severe asthma, the child will be too breathless to talk or feel. Tachypnea and tachycardia will be there. Use of accessory muscles of respiration will be there. Saturation will be less than 92%, and PEFR will be 30 to 50% in a child more than or equal to 5 years. What are the features of life-threatening asthma? In life-threatening asthma, again saturation will be less than 92%. The child will be cyanosed or pale. The air entry will be decreased, or the chest will be silent on auscultation. The respiratory effort will be poor. Consciousness will be altered. Child can be irritable or exhausted. PEFR is less than or equal to 30%. What are the differential diagnoses of asthma? You have to think about an inhaled foreign body, pneumonia, pneumothorax, aspiration, cystic fibrosis, tracheobronchomalacia, gastroesophageal reflux, or hyperventilation. Now, let us go to the treatment of asthma. In a case of mild to moderate asthma, you will give salbutamol, MDI, 2 to 10 puffs via spacer plus or minus face mask in a child. More than 5 years, don't use a face mask. Less than 5 years, give spacer with face mask. So salbutamol MDI and oxygen only if saturation is less than 92%. And you can give oral prednisolone once daily dose. In less than 2-year-old child is 10 mg OD. 2 to 5 years it is 20 mg OD. More than 5 years 30 mg OD. And more than or equal to 12 years it is 40 mg OD. And reassess every 15 to 30 minutes. You reassess the child. In a case of severe asthma, you will give oxygen, salbutamol 10 puffs by MDI or nebulized salbutamol with oxygen. In less than 5 years, the dose of salbutamol is 2.5 mg. 5 to 11 years, it is 2.5 to 5 mg, and more than 12 years, it is 5 mg. And you can add ipratropium bromide if poor response to salbutamol alone. The dose of ipratropium will be less than 12 years, it is 250 microgram, more than or equal to 12 years, it is 500 microgram. Combine the nebulization, like with salbutamol, you can add ipratropium. Together, you can nebulize every 20 to 30 minutes for the first 2 hours. Then you can add oral prednisolone once daily, or in a case of severe asthma, you may have to give hydrocortisone 4 mg per kg 6th hourly. Now let us come to the management of a life-threatening asthma. Admit the child in PICU, inform the consultant. Start oxygen by mask or nasal cannula and give continuous nebulized salbutamol at 6 to 8 liters per minute. Ipratropium bromide nebulization every 20 to 30 minutes for the first 2 hours. Hydrocortisone by slow IV injection in the dose we mentioned earlier. If symptoms improve, reassess the frequency of bronchodilator therapy. And then nebulize salbutamol 1 to 4th hourly and ipratropium bromide 6th hourly. You can space out. But if the child is not improving with continuous nebulized salbutamol, what you will do? You have to give magnesium sulfate IV bolus. The dose will be 40 mg per kg, maximum 2 gram. 40 mg per kg single dose. in a child more than 2 years, 2 to 17 years, and the bolus is given over 20 minutes. And when you give the bolus, you have to monitor the heart rate, respiratory rate, and blood pressure every 5 minutes, and saturation to be monitored continuously. If the child is not showing improvement, you can either give salbutamol bolus or aminophylline loading followed by maintenance. What is the dose of salbutamol IV bolus? In 1 month to 2 years, it is 5 microgram per kg, and 2 to 18 years, it is 15 microgram per kg. And when you give salbutamol bolus, you have to monitor the heart rate, respiratory rate, BP, and saturation. Then along with that, you should monitor the ECG and serum potassium also. Or if salbutamol IV bolus is not available in your center, IV salbutamol is not available, you can give aminophylline IV loading, then maintenance dose. What is the loading dose of aminophylline? It is 5 mg per kg and maximum dose is 500 milligram per dose. Maintenance infusion in a child 1 month to 11 years, you will give 1 milligram per kg per hour, and 12 to 17 years, you will give 500 to 700 microgram per kg per hour. If still not improving, you have to start with IV salbutamol infusion, and the dose is 60 to 300 microgram per kg per hour. So, in a case of mild to moderate asthma, you will give salbutamol by MDI and oral prednisolone. In the case of severe asthma, you will give salbutamol by nebulization plus or minus ipratropium bromide very frequently in the first 2 hours and then space out. Along with that, you can add oral prednisolone or IV hydrocortisone. In the case of life-threatening asthma, you have to give oxygen, continuous nebulized salbutamol, add ipratropium bromide, IV hydrocortisone. If not improving, you have to add with IV Maxilf bolus. If still not improving, give salbutamol IV bolus or aminophylline IV loading followed by maintenance. Still no improvement, you have to put the patient on IV salbutamol infusion. So, while managing a child with acute asthma, you will step up or step down depending upon the child's response. And once the child is better, you will discharge the child. So, what is the discharge criteria? When the saturation is more than or equal to 94%, the vital signs are normal, that there is no tachycardia or tachypnea. PEFR is more than or equal to 75% of predicted. The child is stable on 4th hourly treatment. Very importantly, parents should understand the inhaler use. There should be a written personal asthma action plan. And parents should know to recognize the signs of deterioration and what actions to take. And what treatment you will give on discharge? You have to give a beta agonist with spacer, prednisolone daily for 3 to 5 days. Educate on the use of PEF meter. Tell them to follow up with GP in 48 hours. If there are symptoms of allergic rhinitis, you have to treat that. If the patient is an adolescent or smoking patient, tell them to stop smoking. Other children should avoid passive smoking. In the case of life-threatening asthma, you should refer to a pediatric pulmonologist also for their expert opinion. And when will you give regular preventive therapy in the case of asthma? If the episodes are very frequent, the child has to use bronchodilators more than 3 days per week. If there are nocturnal or exercise-induced symptoms, or if there is family history of atopy or strong atopic symptoms in a patient, you have to put the patient on regular preventive therapy. That means regular inhaled corticosteroid or ICS plus LABA, depending on the JINA guidelines. So it is a totally different topic. We will discuss it in a later session. Thank you.